This module models a team discussion. The ideal team discussion is very brief, 2 to 3 minutes at the most. It starts with the physician providing the background on the patient, the physical therapist providing an update on the areas of progress and areas of challenge, the psychologist providing the same information, and then the discussion as to where the focus on the progress should go next.
Elizabeth and Jeff, thank you for seeing John. As you know, John is a 28-year-old man that is having chronic back pain for the past 3 years after lifting a TV. Due to the pain, he's unable to stay at work. Prior to even my seeing him, he had a lot of tests that showed that the lesion, there was nothing to operate on. He has been on gabapentin, didn't help too much. Try injections, helped a little bit. He started physical therapy in the past, but then he didn't continue because it was too painful. And somebody before me started him on OxyContin, 15 milligrams 3 times a day. I think that I am doctor number 6. So I truly appreciate that you guys have seen him and see what you thought in this past 2 weeks.
Well, just speaking to the OxyContin, are you going to address that? Is this a medicine you're going to continue, or are you going to begin to?
I would prefer to wean him off.
Okay.
I'm just not sure that when I met him, he was ready for this, and that's why I wanted to know where you guys are at this point.
Okay.
Yeah, so from a physical therapy standpoint, he's having a lot of trouble standing and walking. So he's limited to about 15 minutes of standing, walking before he needs to lie down or do something to reduce his pains. He tends to rely a lot on medication for relieving his pain, so that's something for us to address together. He wants a quick fix, and so we've worked on talking about that this is a bit of a long process, but he seems to buy into that a little bit. He's been really perseverating on this disc that they found on MRI. So, but he's starting to come around to some of his emotions and stress, and his mood has some influence over his pain. He does get stressed at work a lot, and is concerned that he might lose his job because he's just not being able to function and perform the way he's supposed to. So.
Did you address a little bit the OxyContin with him?
We did. We talked about the issue of the degree to which, just to set the stage for that, I think that there is more depression here than he's acknowledged. And we talked, as we're trying to introduce depression as a concept that is comorbid with his pain, and normalize that a bit. We also talked about the potential mood effects that OxyContin can bring along with it. And he is beginning to show some signs of accepting that. He's got some anxiety as well. There's no evidence that I can find of substance use disorder, so our effort's really going to be on articulating the elements of depression and anxiety, depression as a consequence of his feeling demoralized and punished by pain. But also because of some of the sense of disbelief that people in his environment have had. And he's got some apprehension about engaging. So we're going to address pain beliefs as well, and to help him understand, along with Elizabeth, that the things that he needs to be doing physically aren't going to be harmful to him.
Thank you so much, and I will try next time I see him. I think he needs to know that I believe him, that I truly understand that he's in pain. But just doing nothing is not the way to get better. So when I see him next week, I will emphasize the importance to continue working with you guys, the importance of doing a little bit rather than just lying in bed all day long.
Well, and I think also helping him to establish realistic expectations, that this is going to be a slow process, that it's going to take some time, that there's not a magic bullet, that we're not going to take the pain away right away.
And do you think I should address the OxyContin now, or shall we wait a little bit since he's holding so tight on this?
Well, I think there's some risk that this is doing more harm than good, so I don't know that it's a good idea to delay that titration. But I also think that this is, as you said, he's in a pre-contemplative state. This is a time for us to educate him And you can address that from the perspective, from your perspective, and I can, and Elizabeth can, from the perspective of it's interfering with his
Yeah.
emotional and physical function.
Yeah, maybe, I don't know, I will review how much gabapentin he was on, but maybe we can maximize that a little bit, or maybe add a tricyclic and see if that helps him, and then see how he responds to that while we transition and educate him, and he gets more active in his role of taking ownership of the disease.
I think that makes sense.
Thank you.
Thank you all for modeling this team discussion. As you can see, the team began with a report from every provider, then identified the challenges and the areas of progress. They had a thorough discussion about the possibility of substance use disorder, which was absent, but did determine that tapering the OxyContin was appropriate now. They identified the stage of change that the patient was at, which was somewhere between pre-contemplative and contemplative, and had a plan to go forward together.